this group of non-communicable diseases is getting out of control, hence the need to discuss the challenges and innovations in the management of these diseases, and hence the theme of this University of Nairobi Kenyatta National Hospital Health Symposium. My name is Dr. Oiro. I'm a lecturer at the University of Nairobi, the Department of Clinical Medicine and Therapeutics. I'm a hemato-oncologist by profession. I don't know how the management of the symposium settled on me to moderate, but I take it in stride, and I think we'll move together. Now, this is just the first day of this health symposium, and we give diabetes its rightful share of of appreciation, and we are going to start with diabetes today. You will be getting notifications an hour before each of the meetings. We have hematological diseases. We have a number of specialty diseases lined up for discussion. If you are hearing me well, if not, then you can always interrupt. We are waiting for our dear Prof. CF Otieno. He's supposed to give us a keynote address. Prof, if you have joined, you just let me know so that we can start. If in order to save time, if Prof is having challenges joining, then I will request our panelist, whoever is ready to start us off, then we can invite so that we manage the time. Dr. Katambo, you think you are ready to start us off as we wait for Prof. CF, because I cannot see Dr. Oburu?
Yeah, I'm good to start if that's the case.
Great, Doc. I think
it will look weird for me to speak before my video is not active, before my boss CF Otieno Prof.
But yeah, I think Dr. Juka is trying to follow that up. You see, now we are 12 minutes into the time, and we have a very tight schedule. So it might be we might run out of time if we wait for
okay.
Yeah.
Then in such a case, then
yes. So
you need to stop sharing. Well, so you can see my screen.
Perfectly.
Yes,
so my name is Dr.
Let me just say something small about Dr. Katambo. For those of you who may not know him, he's an experienced physician with expertise in lifestyle prevention and management of non-communicable diseases, with a particular interest in weight loss management and reversal. Those of us who get into the social media, you will find Dr. Katambo with very key information on how to lose weight and manage these non-communicable diseases through lifestyle. And he's actively involved in the implementation of diabetes reversal program for people living with type 2 diabetes, both locally and internationally. The programs been quite successful and have helped participants adopt healthier lifestyles, lose weight, and gain better control of their blood sugar and achieve type 2 diabetes remission for quite a number. As a result, it has led to the reduction of complete cessation of use of medication, both for diabetes, hypertension, and other conditions. He also runs courses in principles of type 2 diabetes remission to educate and create awareness of type 2 diabetes remission among healthcare professionals in Kenya, Africa, and worldwide. He's the CEO and founder of Clinic Reversal Limited and AfyaCode Limited, the first clinic in Kenya focused on type 2 diabetes. Dr. Katambo graduated at the University of Nairobi in 2006. He He was actually my senior in undergraduate with a bachelor's degree in medicine and surgery. And he also holds master's in public health from the University of Nairobi. He's a member of the Royal College of Physicians, and he also holds certificates in lifestyle management. Dr. Katambo has played a key role in the establishing of the first diabetic reversal programming in Bermuda. And following the program's success, he actually returned to Kenya to establish the first diabetic reversal program. So, ladies and gentlemen, we're actually going to hear from the best in this reversal of type 2 diabetes. Welcome, Dr. Katambo.
Okay, thank you so much. I don't know whether you want to see my face, but the video is inactive, but I can still go ahead with this. I don't want to repeat who I am, but I have no conflict of interest in this forum. It's only that I have an upcoming book that's called Food Carb Atlas. Maybe that's the only conflict I might have, and I might be more biased towards lifestyle change. Other than that, exactly the reason why I'm here is because of lifestyle change. Now, diabetes, as we might know it, and you might see this with the rest of the speakers around, is commonly, of course, increasing worldwide, but of scale, most is in Africa. Africa in the next 20 years is going to have a triple-digit increase in type 2 diabetes. And as you can see, the rest of the world, yes, there is an increase, but Africa is the most prone to 3-digit increase. So we need to do something to make sure that we deal with this pandemic. We all know type 2 diabetes is a disease that is associated with an activity, unhealthy diet, and mainly sugary refined foods. And we know soon after high school or campus, we all start gaining weight, and then at some point we get pre-diabetes and then diabetes and then complications. So we know the numbers, we know what causes diabetes, but what do? We still don't do much in terms of prevention. Now, in the Western world, as you can see, the consumption of ultra-processed foods is way up there. But as you can see, in countries like North America, ultra-processed foods consumption, they have realized something is happening and they're trying to, cap the menace down. But in Africa, the numbers seem to be going up. And as you can see, or you have noticed, the number of processed food kiosks like fast foods are cropping up every day when you walk in the cities of Nairobi. And the same is happening to drinks. On your right here, you can see the number of, especially in Africa, we seem to be increasing the consumption of ultra-processed foods. And what does that lead to? It leads us to development of type 2 diabetes. Just a caveat. In 2015, IDF projected that the number of billions of shillings being used on diabetes alone was $673 billion. Now, in the next 20 years, it will be around $802 billion. Now, the question is, why are we going wrong? And when we are using this money, we are also developing the same drugs. In 1894, it was projected that we had only 48 drugs for use of diabetes. Or type 2 diabetes. And right now, around 2017, we had close to different molecules of drugs, including insulin, 488. And yet the pandemic continues to increase. So there must be something that we are really closely not monitoring or observing clearly. We know very well that the twin cycle hypothesis that were postulated in 2011 or 2015 by Professor Roy Taylor, what tends to cause type 2 diabetes? Usually, I know this slide is usually busy, but as long as you have a positive energy balance in your body, the liver tends to accumulate fat, and your pancreas also tends to accumulate fat. I've looked for a simpler way to put this, and this is in the next slide, where if you have a high glucose levels in your body, insulin production is usually high and tends to increase fat deposit in the liver. You will gain weight, and this is what I showed you on the first slide, the first two slides. You will continue gaining weight slowly, and unfortunately, you'll also have deposit of fat in the pancreas. And with time, the production of insulin production of normal good endogenous insulin tends to slow down, and you develop the insulin resistance, especially from the liver, and that leads to type 2 diabetes. Now, when you put that into perspective of radiology, on your left, you see a normal radiological liver image where the fat content is not as much, it's usually about 5 to 10%. Sorry. Usually about 5 to 10%. In type 2 diabetes, by the time somebody is being diagnosed, you see an increase of about 20 to 30%, and that is well demonstrated by the white stuff you see on the liver on the right side. So we know again that type 2 diabetes is actually preventable if you increase your physical activity and you eat healthy. And we know this because if you actually increase your physical activity and you eat healthy, you will see even some, now we're seeing even patients who have had some mild complications improving, diabetes improving, moving from pre-diabetes to normal levels. So it is possible to actually put that same process into reverse, or you kind of like take it down again. And how do you do that? There are several ways which you can lower your energy intake or your carbohydrate intake. Let me use that word. And there are many postulated ways which you can do, all which lead to lower glucose levels, lower insulin levels. Remember, the hormone insulin is the problem here. It's not your calorie intake. You can get your calories from many different, even including proteins, fats, and the rest. But what raises your insulin levels is usually glucose most of the time. So what happens is if your insulin level is down, then you lose fat in the liver, you lose weight, and you reduce pancreatic fat, and this will eventually reduce lead to insulin resistance. I mean reduction in insulin resistance, and therefore increase in your endogenous production of insulin secretion, and this leads to reversal of type 2 diabetes, or correctly put, remission of type 2 diabetes. Now remember, the steps for type 2 diabetes remission are quite obvious, or they are known. That is, you reduce fat in the liver, you reduce fat in the liver, and you will also be able to reduce your very low density lipoproteins. This tends to reduce the pancreatic fat, and beta cell function will improve. Now, if you, for some reason, if you go back to the same consumption of highly processed carbohydrates and a lot of carbohydrates, even in our own home here, endogenous, what I call foods here that are full of starch, our foods are really full of starch, we will still end up with a lot of, you will reverse the process and you will revert back to type 2 diabetes. So it's very important to know that in as much as type 2 diabetes can be put into remission, remission is also reversible, and somebody has to be encouraged to keep at lifestyle. Now, the current definition, we have had a lot of changes in terms of definition of type 2 diabetes remission, but the most current one was postulated last year in August by a consensus report, and currently it stands at an HbA1c of less than 6.5, and you must be off all glucose lowering medication for the 3 months. So if you acquire an HbA1c of less than 6.5 today, and we stopped your medications, and then we recheck your HbA1c in the next 3 months, and it's still less than 6.5, then we say you are in remission. There's a term that people are using right now, and it's called a reversal. And many people tell me, oh, why do you keep saying a reversal? Reversal is actually has a place. Reversal is when you achieve HbA1c of less than 6.5 in the next 3 months, but you keep metformin. So do we have studies that are prove this to be of use? Yes, we cannot talk about type 2 diabetes remission without referring to the direct clinical trial. I'll not give you all the details about the direct study or the clinical trial that came out, but this shows you a little bit of like an extension of 24 months that was released. I think it is 2019. And as you can see on your right, the patients who are involved here lost about 9 to 10 kilos, and within 24 months they had lost, they had gained a little bit to 7 to kilos, but the HbA1c remained low. So if you started at 7.7, you went to 6.8, and there was a little bit of an elevation by 7 to 7.1. But look at the remission rate. The remission rate, in as much as it didn't match with the weight as much, because we know we need to lose about 15 kg, 10 to 15% of your body weight to get into remission. At the baseline, we had 0% remission rate. At 12 months, we had 46% remission rate. And at 36%, at 24 months, we had about 36% remission rate. Now, if you look at the controls, you can see we only achieved remission in 4% of the people in remission. So if you have 100 people and you put them into the direct sort of like treatment that they used, in 2 years' time, in 12 months' time, you will only have 4% having a remission. But if you use a low-calorie diet, like what energy diet, that like what was used in the direct study, you will be able to elicit about 46% remission rate, which is quite commendable. Now, the other study that we cannot highlight in this case is the VitaHealth, which utilizes a very low carbohydrate approach. This is quite restrictive, and the good thing is that they demonstrated to us that weight loss is actually key in type 2 diabetes remission or reversal. And again, as you can see here, in the 2 years, we had patients lose about 12 kilos. HbA1c dropped from 7.6 to about 6.7. And again, you can see at 12 months, we had 25 on treatment and 24% on metformin, 18% at 24 months, and 35% still were on treatment. 18% were on no treatment at 2 years, and 35% on metformin. So in this case, VitaHealth is big on reversal. To them, they want patients to just be on one drug, that is metformin. But the most intriguing thing in this slide here is what is on the left here. Out of all the patients that were on insulin, you can see about 48% eliminated insulin completely. About 100% of those patients who are 53 in this study, who are on sulfonylureas, eliminated completely sulfonylureas. The next thing was the SGLT2s. And I know sometimes the cardiologists, the diabetologists, and the rest of us in the diabetes world, we tend to use a lot of SGLT2s, which is key, and they have been shown to be quite effective. But we know very well there's quite a big debate on whether lowering carbohydrates is equal to giving an SGLT2 inhibitor. In this case, as you can see, these patients went to a very low carbohydrate, and they were able to eliminate about almost 91%, and the rest of the drugs, as you can see there, were eliminated in equal measures. Now, when you look at it from a practical measure or practical point of view, the low carbohydrate approach is the most practical way to do this. And this has been demonstrated, especially in UK. We have several studies that I will not go through, but this is an interesting clinical perspective. I know we have so many, now we have several clinical trials that have shown the same, but I wanted to highlight this from a clinic perspective. Dr. David Unwin published this paper, I think it was in 2020 or something, yes. And as you can see, out of the 128 patients that he was able to follow, at 23 months, 46% of those patients who are coming into his clinic were actually in remission. And remission means that they are not on medications. Now, remember, there are others who are still on the same program, but they always get other benefits. They have lost weight, they're still on insulin. They were using insulin, maybe 100 units, now they're using 20 units. So in whatever way you want to look at it, low carbohydrate approach has been shown to be quite effective. I do not want to really bother you with the rest of the statistics, but you can see the rate of the statistics was really, really significant. Total cholesterol, HDL, total cholesterol, HDL, which we, and also for blood pressure was quite significant. Now, the same guy proved that through approach of...
Katambo, you have about 3 minutes, so you can begin to wind up about 3 minutes.
Yes. Yes. So he showed that through this approach, he was able to save about 6 pounds from each patient that he had on the clinic. And when he extrapolated this to his clinic to about the same number of patients that he had, you can see he was able to save around 50,000 pounds per year per patient. So it's quite important for us to know that this can be achieved and it's actually possible. Now, I know I have 3 minutes. I probably will just flip through the rest, but this slide is really important because no matter how you look at HbA1, I mean, you look at the cardiovascular approach and risk improvement in these patients, they all improve all measures of cardiovascular risk factors. But we have seen a 10% increase in the LDL, where we have the normal hyperrespondent and the lean mass hyperrespondent. And the best studies that I know of, about 2 to 3 studies that are following up on this 10% of patients. So how do we put this into practice? Please remember that it's very key for you to put this into practice in caution, because patients can go into hypo, especially if they are on sulfonylureas and insulin. How do we do this? You have to put in perspective the patient, you have to personalize this. There's so many factors that we have to look at. Cultural beliefs for this patient, education level, labor force, food availability, physical activity, mental well-being. You have to look at the patient in that perspective so that you know what exactly to avoid, to advise these patients on. And how do we approach this from a clinic point of view? It is very easy. Remember, we said all you need to do is reduce the amount of carbohydrate, not necessarily the calories, but the amount of carbohydrates. In this picture, I demonstrate to you 2 equal 20 grams of carbohydrates. On the left is 20 grams, and on the right is 20 grams. On the right, you will have a spike in insulin. On the left, you will not have a spike in insulin. That's the same picture. If you had a breakfast of bread, and this patient comes in with, takes in two slices of bread in the morning, you will see a spike of sugar, all right? Because 2 slices of bread is about 8 to 9 teaspoons of sugar. So you'll see this spike. And the patient will come in that during lunchtime and tell you the sugar is up. But if they consume just eggs and some meat and some vegetables, the sugar just remains quite stable during the day. So it's quite, from a practical point of view, you just need to eliminate the starches and there you go. Ugali and you're good to go. When you look at our African foods, we need to tell the patients that for sure they need to eliminate or really lower the intake of fruits, because we tend to say, I have seen so many patients come to my office and I take a lot of fruits because I was told they are healthy. Now, if you eat 1 mango, it gives you about 14 teaspoons of sugar. If your sugar was 6, I don't think your sugar will be 5 in the next 2 hours. It will probably be 9. So you need to advise your patient accordingly. The same happens to something like an orange has 4 to 5 teaspoons of sugar. A chapati will have squarely about 10 teaspoons of sugar. So you have to be good enough. You have to tell your patient even a brown chapati can be equally raise their sugars. Uji, I have compared uji here, brown uji and white uji. Which is almost equivalent, as you can see. It's about 8 and the other one will be about 10. So there is not much of a difference. Ugali, my brothers from Western, they suffer a lot because they tend to take a lot of ugali, and not just Western. I think ugali is a staple food everywhere. And you can see these 2 small fist size tend to be about, 14 teaspoons of sugar. So I brushed through. But as you can see, starches can have a lot of sugar. So it's very important for you to advise your patients accordingly. Now, when you start this from a practical point of view, Be aware of the side effects. It's very important to advise your patients on the side effects of this reduction of or lifestyle change, and especially keto flu, some headache, fatigue, weakness, and dizziness, mild headaches, and some muscle aches. They're very common, especially in the first 4 weeks. So you need to be careful in this.
Yes, Dr. Katambo, you can wind up.
Yes, please. I'm winding up. So your patient, make sure that your patient is followed up. There is always the initiation point, the transition point, and the maintenance phase. We always say being number one is not a problem, but the problem is maintaining being number one.
Yes,
so it's very important for you to assess and make sure that you deal with.
You sent me your email.
Sorry?
Oh, just send me your email. I've tried inviting you through, asking for the email.
Oh, sorry. So this is the common analogy of what we see in the clinic. As you can see, I saw this patient first in December last year, and you can see an HbA1c was 11. They were on the common low-fat diet, but I changed them to a common newer intervention that is low carbohydrate diet, and we have seen an elimination of almost completely all the drugs. This was as late as just like 2 days ago, and I mean 4 to 5 days ago. And now I'm just waiting for the next 3 months. If I check and that HbA1c is 5.5 or less, we will have the same. So it's very important for us to see, and we have so many examples of same patients. And so in summary, type 2 diabetes remission is gaining momentum worldwide. Whether we like it or not, we need to embrace this. We need to make sure that all patients get these services in our clinic. In many countries, type 2 diabetes is becoming, remission is becoming standard of care. Remission is best supported from an interprofessional teamwork, and new payment methods are coming up. Insurance companies are now supporting this. We have organizations that are supporting this, and healthcare professionals have an ethical obligation to make sure that we inform our patients that type 2 diabetes is can be put into remission, and especially within the next, if it is occurred within the last 10 years. Thank you.
Okay, fine. Thank you, Dr. Katambo. That was a very inspiring talk. So without wasting much time, I think questions and answers will be tackled at the end. It is my pleasure now to invite Professor C.F. Otieno. I think Professor C.F. Otieno is a domestic name in the field of endocrinology and diabetes. Prof is currently the Associate Dean, Faculty of Health Sciences. Is a fellow of the Royal College of Physicians, a very experienced physician and diabetologist with over, I think Prof is an academic par excellence. I was just looking at his publications, and I feel very intimidated. Over 70 publications in peer-reviewed journals. And I think Prof also, in terms of training, Prof has supervised more than 50 MEd student dissertations. And without wasting much time, I think, Prof, it is our pleasure to listen to you. Prof is going to give us a keynote address, so we'll accord him a little bit more time, 30 minutes. So Prof, if you're ready, you're welcome, sir.
Thank you, Peter. Thank you for the kind introduction. Can you see me?
Yes, yes, Prof, you can see your slides very clearly.
Yes, thank you. Sorry for the technology. The internet wasn't there when I was in the office. It was on, unstable, so I decided to seek a new site. So having said that, my presentation is on challenges in diabetes care and innovative solutions. That was the end of the suggestion, but I've added, for my purposes, perspectives and proposals. And I want to thank my very good friend, the young man, Dr. Katambo, for bringing out the issues I want to talk about very, very tacitly in his presentation. And I would like to go through them and then you see what are my perspectives, what are the proposals in our context as a hospital, as a profession, as a region, and all that. Thank you very much. Next slide. Next slide. The slides may look very, very busy, but I want to bring out the context. They are not the issues of discussion. That slide is bringing out the state of diabetes treatment coverage in 55 low-income and middle-income countries that Kenya belongs to. And that is a Lancet publication by that team. And they have given us a background that 80% of all patients with diabetes, type 2 especially, worldwide, reside or live in the low-income and middle-income countries. Consequently, it is a problem of numbers. And from their study, the estimate is just about 5% of individuals with diabetes who made a self-report of meeting the needs of diabetes care is very low. 5 out of 100 is very, very alarming. It is small and it should raise concern. And it therefore means that fewer than 1 in 10 people receive coverage of sufficient standard diabetes care. And that is a case of concern. So that's the magnitude of the problem. We have the numbers and we are not meeting the required needs. Even if we were doing it in KNH, have we reached a level where we can scale what we are doing, scale up what we are doing countrywide? The answer is no. Next slide. Next. So I have put before you the times or the eras of diabetes care over the years before the discovery of insulin all the way, and somebody has looked at the future, that there were deaths all over. Then after insulin, however crude it was, that patient called Johnson who received insulin, however crude it was, actually survived to die of infection later. Then after the insulin, which has been refined over time, we can monitor, we can diagnose, and talk about prevention. We are managing, yet our approach was, if this doesn't work, then try add this extra. If also that combination does not work, can you add the other? What we were referring to as treating to fail. Now, we are in the era of optimizing treatment. We add treating to success, and we start with a successful combination and drop them off as necessary as time goes on. So what does the future hold for us? If we are optimizing, we have technology, the machines, the strategies, and all that. Where are we into the future? I want to persuade you that indeed our challenges remain like the pre-insulin days, the 80s, the 70s, 80s, and 90s. We have just had a touch of the future but it has not permeated us. So I'm looking at challenges in a very, very realistic way, and the innovations must also address more of our challenges than just go with the wave. Next slide. So the challenges in diabetes care for people living with diabetes, as I've said, from the Lancet publication, is limited access to care. Our patients, most of them are not aware, even if they are aware they have diabetes, they are not aware of the magnitude of the problem, the burden within them that now calls upon a personal commitment to control diabetes. The systems do not provide initiatives to diagnose diabetes early. Why? Because our health system is crafted for acute care. If you just walk in that I'm peeing too often, just a bit tired, be sure that somebody in A&E will send you away, you're wasting my time, and say, can you give me patients on stretchers? Then of course, the weight loss, the issues surrounding the early manifestations of diabetes, poor vision, weight loss, neuropathy, or pain without obvious injury, seem to fit in the cultural beliefs that somebody is bewitched and they seek alternative ways of addressing the health challenge rather than making the diagnosis. So apart from just being unavailable to, or being unable to access care and do the right things about knowing whether we're diabetics, and then we know there are now challenges in people who have known. They're in poor metabolic control, they have very poor health literacy. That means they cannot make conscious decisions. They do not have the sufficient knowledge to make conscious health preserving decisions. We use alternative herbal remedies, which are unproven. The spirit is willing, the pocket is weak, financial barriers, so to speak. The dietary recommendations may be difficult to follow because the reasons for feeding, the reasons that we eat are very, very varied. And Dr. Katambo has already alluded to the diets. Then we have comorbidities from our own publications. We have comorbidities of depression, and worst of all is communication with our providers. That is between us as professionals and the patients. Next. Next slide. So then, what are the documented barriers to effective diabetes care? I've talked about the health systems, that we are crafted for acute care. The systems are insufficient where they are, and they do not address the specific needs, and they are also very few. Within those healthcare centers, the healthcare providers skilled in diabetes care are either not there or they are very few. And when you have prescribed or you manage to see the few, what has been prescribed is in short supply, or it is not supplied at all. And many who are as old as me in UoN-KNH, not too old, but in recent times, there was one supply chain that was corrupted to reflect a new supplier who brought a generic insulin that rendered a whole clinic for as long as that was dispensed out off control, and some were admitted. I'm sure 1 or 2 must have died for falling into DKA. So supply chain. Then do we have the right performance measures to benchmark what we do, that we are doing the right thing for our patients? But even then, as a center in KNH, do we coordinate care with Mbagathi, Jericho, Mama Lucy? We share patients, but we have no coordination of care. Next slide. So then, the key challenges and unmet needs in diabetes management closer to the clinic are suboptimal A1C control persists. From our own publications, less than 40% of our patients are in good control when we studied them, but less than 20% stay in good control for as long as we see them. And I will tell you from our own studies in KNH, the people who are in proper control, on desired metabolic control, are actually patients who are on diet and physical activity, not the ones we treat. Indeed, the ones that are on insulin are the worst, have the worst metabolic control. That means the healthcare provider is doing so little. The other key challenge in the clinic is the complexity of diabetes treatment. Dr. Katambo there is telling you, just do diet, reduce this, reduce that, add that, and you'll be fine. And somebody else is prescribing, this is the latest medicine in town. And somebody else is saying, you must do exercise to this magnitude. And I can't run, my muscles ache. What do you prescribe for all these with heterogeneous needs? 95% of patient care is self, and there's poor patient adherence to diabetes management prescriptions. So that is a key challenge and an area of unmet need. And like I said, the costs are enormous. And this is a disease that you are getting into at, around, or after retirement, when the healthcare, the health cover, the salaries are not there. Next slide. Next slide. Now, I'm coming closer home to the clinic, that patients with type 2 diabetes, what are the obstacles in coping? And I'm questioning the role of the healthcare provider. If we keep to the target that the key challenges in diabetes management and the solutions, I'm highlighting these challenges that are within your area of operation, and the solutions certainly are not going to come from China. They're not going to come from the US. There must be best practices that we can share at the end of this presentation that will provide us with hope. So the patients with type 2 diabetes mellitus, what are the obstacles in coping? And in that study, 1, medication obstacles, the self-monitoring obstacles, their knowledge and belief, the obstacles in diagnosis I've talked to, but I'm underlining obstacles in the relationship with healthcare professionals. There is one which is implied obstacles in receiving suggestions and support if you are in poor relationship with your provider, it's very unlikely that you trust them and uptake their pieces of advice. And in one study that I've also quoted there, where meta-analysis was done, and the concluding statement was that interprofessional collaboration interventions are required in response to patient-reported outcomes. And the people who make decisions on healthcare must adopt a collaborative approach to care designs. And that is critical because it is an aggregation of studies with that final piece of advice. Next slide. So we've talked about access as a key challenge. What are the key dimensions that are impacting access and optimal use of our digital platforms? When people hear digital, they all wake up and they're excited. But there are issues. When you say value-based contracting and outcome measures, there is a concept now called patients' journeys through the continuum ranging from symptom access to care, diagnosis, and then evaluation, follow-up, and then determination of need. So within that area within that spectrum, one can determine what they call a value-based contract, that I have neuropathy. How do you diagnose it? That is my presumptive diagnosis. How do you diagnose it? And how do you, what do you do about it? Somebody comes, I have symptoms of poor control, and what do you do about it? Then, of course, the adoption of technology, some need it, some don't. Some need it, yet they can't afford, so they can't access it. And then, of course, some are covered, they can be reimbursed. Others cannot because they say pre-existing. Then personal experiences, then marketing approval. As Dr. Katambo told you, that when you restrict calorie, the drugs that cause cellular calorie restriction as of now are SGLT2 inhibitors. But they're not approved for that purpose to be prescribed for preventive purposes. So market approval is an issue. Then, of course, people who have accessed new technologies, do you have the luxury of interoperability? No. What about data? Who needs it and who has access to it? Next slide. Next slide. So then, of course, the digital health products are here with us. People are excited about them, but are they appropriate when they are given? The question is yes. They may be. The answer is yes, they may be appropriate, or no, they may not be appropriate. But they are marketed very, very freely. So digital health, digital therapeutics, we have the insulin delivery pumps, the continuous glucose monitors, and all that. So that one I'm leaving to you to see if what we have talked about in the previous slides find solution in that digital platform. Next. Next slide. So somebody said, how can countries innovate and manage diabetes in a low resource setting? And the answer was, adequate healthcare demands a basic level of resources, so we must provide resources. One of the greatest innovations in a low resource setting would be to change mindsets. And maybe that is what drove me into taking this direction, that is the mindsets that we want to innovate or to change innovatively, so that we consider investing in keeping our people healthy rather than fixing their problems. And we train, and I want to stress that, train the healthcare professionals and make them service ready to provide appropriate services to our patients. And we share that knowledge at a much greater scale. And I think this forum is an example. Next slide. Again, that is, somebody say, integrated personalized diabetes management. But there will be a slide that will be a very good benchmark that will raise some standard questions, so that as we come to the conclusion of this talk, you will know where our challenges are. Structured training and evaluation of treatment, assisting with the decision-making, documentation, that is records, and then of course guideline assisted therapy and self-management. Next slide. Next slide. I am off. Next slide. So then, whatever the precise design of our health system, the fundamental role of performance measurements is to help hold various agents to account. Both patients and providers must be held accountable, and this is on the informed decision making. And if accountability relationships are to function properly, no system of performance measurement should be viewed in isolation from the broader system design within which measurement is embedded. I want to summarize it this way, that even as a hospital, just giving me a patient to see to ensure I saw a patient is a bit too narrow. We need to operate as a collaborative group of people and interact very closely with the health system, so that each patient experience, the patient who comes to see us has a very useful and memorable experience, and they'll keep coming and call more to come. That's accountability and witness. So we need to set such benchmarks as a hospital to improve our care provision. Next slide. So this is now the solution. That looks sophisticated, but our health system dynamics framework is where our solutions, innovative solutions, lie. We need very participatory leadership and governance, where the professionals try out or discuss issues. The resources will always be scarce, but we want to maximize, and I will tell you how we can maximize at the end. So that resource allocation is following what we call a differentiated service delivery pattern. Then we can be accountable for the outcomes for those group of people in terms of immediate, medium term, and long term. Both for our patients, the general population, when patients are healthier, they spend less on health. Next slide. Therefore, our innovative organization diabetes care will lie, one, in delivery system design. We want teamwork, team, and subsequent slides may show that teams work. And who are members of this team? We have nurses, we have dietitians, pharmacists, psychologists, physicians, surgeons, and all that. So teams, team content or team component, and then the teams must collaborate and work together for the success of that team. Then, of course, what is the disease management model, the care model that we are designing? Next slide. So, do innovative care models work? Indeed, yes. Chronic care model is now tested and tried. The context may be different, but there's evidence of effectiveness of chronic care model for type 2 diabetes management in primary care. The organizations, the organizing, coordination of care and all that may be unique for a health system, but when you use the principles of collaboration, education, standardization, resource optimization, technological innovation, then chronic care model as a design works. Next. The teams also, team-based care has been shown to work. The team-based care improves diabetes management. And from that study, the teams that included patients, their primary care providers, additional health care professionals were shown to improve blood glucose, blood pressure, and lipid levels for those type 2 diabetes patients. And that was an aggregation of randomized control trials. Next slide. What about the records? Now, when you put electronic records, electronic health records or medical records together and add to teamwork to assist there or to provide a decision support system, the evidence is that the impact of electronic health records depends on your organizational context. If you use it for administrative reasons, it won't give you as much as, it won't be robust. So you need a cohesive setting where the nursing makes input, food care providers, the eye examiners, the physicians, the education specialists, they put in data, and then from that study, next slide, the patients cared for by cohesive primary care teams experience modest but statistically significant greater electronic health record related health outcomes improvements, because you aggregate data and use them for decision making at patient or granular level of patient and at clinic level of decision making and resource allocation. So teams, then teams plus robust electronic health records, not for administration only, but for clinical decision-making support. Next slide. Then very critical, quality of primary care physicians' communication of diabetes self-management during the encounters, the consultation. And we are coming from that study where the assumption or the self-reported experience is that there is poor communication. And next slide. The results are the physicians provided inadequate quality diabetes self-management education in all domains. And the quality of diabetes self-management education provided by the physicians was not associated with any of the physicians' characteristics. And the conclusion from that Nigerian study is the quality of physicians' communication of diabetes self-management was suboptimal. And the majority of the adequately communicated diabetes self-management behaviors were risk factor reduction related and disease centered. And that meant we offered very poor emotional support to our patients. And we need to improve on that. Whether that will be digital or whatever, I am not too sure. But next slide, we're almost through. I'm coming. So the patient's perceptions of patient-provider communication in diabetes care has been evaluated there. And the limited evidence shows that patients perceived communication quality as significant and a modifiable component for improving a range of outcomes. And that, for me, is a very important aspect that you've seen. We do not communicate well, and when we do, we are only on the disease component and we don't address our patients. We address the disease. Can we change? Can we be innovative in the way we communicate with our patients? Next slide. Next slide. So in shaping the future of diabetes care, innovation, people, and partnerships are the way to go. And there is how we integrate. Integrated approach is a very innovative way of looking at diabetes care. We integrate services, we approach services in teams, we support those teams using robust electronic health records. And we also communicate, we coordinate this care so that we don't see ourselves as a referral hospital in isolation, and generating policies that are exclusive, but policies that are collaborative. And we use the recommendations as parts of monitoring and evaluation of our strategies. Next slide. Next slide. So I looked at the records and I found that these are the innovations in diabetes care for a better new normal beyond COVID-19. And I'm thinking this must be aspirational. Telemedicine, yes, there was near madness around it. It's working. It is supporting the physical distancing and supports physicians in sharing knowledge. Telementoring, Katambo can now telementor people into Ukana, but there is starvation. I wonder how you want to limit their carbohydrates. Then of course, e-consults, which could be asynchronous or synchronous, but that means the patients must be connected in one way or the other. And team-based care model is still an issue, and we are encouraged to change from my patient, or this is what I do, to this is what we do. We take care of patients, not I do this to my patient, is we do this to our patients. So that is aspirational, but is still doable. Next slide. So that's, when you think it is digital, that's the ecosystem that you must create. That's the Mao forest that will give you the rain for a thriving diabetes care, which is digitally enabled. The digital ecosystem for diabetes care are at the delivery level, monitoring level, the patient care, the continuous glucose monitoring in a wearable device, feeding into a data system with analysis at an interface with the healthcare providers, and you are communicating through those e-consults, telementoring, telemedicine, and because you are interfaced to your multiple teams and you are communicating. Do we have that? I already have problems doing this presentation at a site in the main hospital because the internet is irregular. When shall we have that? We aspire to achieve that, but hear me out, that it is an aspiration, good thing, but not available at the moment at the level of regularity that we anticipate. Next slide. So, cost effectiveness of interventions to manage diabetes. Has evidence changed? The evidence has changed in as much as the things that we've been doing. There were about 10, 11 things that were listed, that usual care versus intensive care, using this versus the other, looking at glucose only versus multi-factor intervention. I've only listed a few that indeed the evidence hasn't changed. Integrate care, you get better. Get your patients to stop smoking, they improve. For those who have indication, use daily aspirin, they benefit. People on insulin, self-monitor blood glucose 3 times a day, you benefit because it gives you information. Intensive care, you benefit at the expense of hypoglycemia. Then collaborative care for people who have depression, and our studies show that 30% have depression, they get better. So these are already there with us, but the latest, for about 20 years now, maybe say 30 years, our publications are still showing we do not control our patients well in terms of pressure, sugar, lipids, weight, knowledge, behavior, and all that. So the conclusion there is complementing professional treatment recommendations. We need itself provides an updated understanding of the potential value of interventions that I've talked about to manage diabetes and its complications. And that will enable us prioritize resource allocation. Next slide. That is a study that we've been part of the past more than 12 years, the International Diabetes Management Practices Study. We did our cycle in Kenya. This is done the world over by Pablo and Tim, and my friends in West Africa, and some in the Far East.
We have 2 minutes to go.
Yes, I'm actually now winding up. That our parameters of control are still showing we have not changed the experience of our patients that much. That very, very small number of patients achieve desired goals, in spite of the technology we are trying to use and the refined forms of medicine. So what is it that we are not getting right? Next slide. That's the same story. In developing countries, glycemic control in individuals with type 2 remains suboptimal over 12-year period, indicating a need for system changes and better organization of care to improve self-management and attainment of goals. That is still the story as we published it last year in June. Next slide. I've given you evidence here that in Europe, they still say the effects of European multifaceted diabetes care patient outcomes are only small. Improvements are somewhat larger for screen detected and newly diagnosed patients than those who have had diabetes. This slide is meant to tell you that even where technology and resources are enormous, there's something human that we are not getting right. So our patients are not receiving the best from us, regardless of resources and the latest of technology. So Africa cannot aspire to do what Europe has had because we shall have a similar experience. What must we do differently? Next slide. Next. The approaches or the areas of need for future innovation, innovative approaches lie in the innovative care management, where we should risk stratify our patients and or facilities, plan well for longitudinal care, both individualized and population health, and episodic care at discharge from assisted hospital care to self-management. Emergency departments, what are the specific unique needs? Transition of care, how you get an adolescent from very dependent to an adult who is self-dependent, and the level of responsibilities. Next. And the strategic directions will still be in the domain of integrated care, where we strengthen primary care, we foster team care, and we are patient-centered. We also facilitate access to care through the right policies and the right providers, and we support our patients to achieve so much on their own without requiring acute care. Next slide. Having said all that, who will innovate to transform the social determinants of health? Next slide. Thank you very much for listening.
Thank you very much, Prof, for such a succinct presentation. Yeah, I think you've raised enough issues to stimulate a wider discussion. Yeah, so for the sake of time, I think we'll move to the next presenter. Prof, there's a panel discussion at the end of it, and I'm sure from the question and answer session, I've seen a number of people interested in some clarifications after. So if you could stay on, that would be great. Thank you very much. So our next presenter is also a very well-known man, Dr. Ezekiel Oburu. Are you on? Maybe we can allow him to share.
I am on.
Great. Doc is an orthopedic surgeon, general orthopedic, but best known for foot and ankle, as foot and ankle specialist. Doc is, of course, an alumni of the University of Nairobi. Doc is very widely read and trained. I cannot enumerate all, but of note, he's a fellow of the Royal College of Surgeons in Trauma and Orthopedics of Edinburgh. Several fellowships in shoulder, hip, foot, ankle surgeries, both in the UK, for example, Royal Stoke Hospital in the UK, foot and ankle fellowship and constructive surgery in Baltimore. Prof was our teacher and very distinguished orthopedic surgeon. So Prof, Doc, you're welcome to give us a presentation on the diabetic foot. Thank you.
Thank you very much. Like you've been told, my name is Ezekiel Oburu. I teach in the Department of Orthopedics, and mine is going to be very brief. In fact, I will yield my time gladly to the next presenter. Orthopedic surgeons, we are really very simple people. We are at the bottom of the food chain in medicine. Things are relatively simple. Okay, so there won't be too many words here. So number one, Jean-Marie Charcot was a French physician. He described what is known as Charcot arthropathy. And the incidence really varies. The diabetologist will obviously tell us more. But it can be 0.1 to 0.7%. That is for Charcot arthropathy. And it can be bilateral in up to 30% of the cases. And a number of these patients are quite morbidly obese. So Charcot arthropathy is not just something that affects diabetics. In fact, the original description was in patients who had syphilis. However, we know it more in patients who have diabetes. And really, this is a presentation about my experience with Charcot arthropathy. I have probably operated about maybe 16 to 20 patients, and this is what I've found. One of the things that we find in orthopedics is that there are a number of patients with foot problems, a number of patients with diabetic foot problems, not just Charcot arthropathy, but in terms of infection or even just deformity or even diabetic ulcers who are not managed well, because I think that by and large, most people do not know that there is a service in terms of orthopedics that we can give this diabetic patient. The other thing that I would say is that we don't work in collaboration with it's not a multidisciplinary team. So the orthopedic surgeon works alone, the wound care nurse works alone, and the diabetologist works alone. At best, the diabetologist will work together with the wound care nurse, and the orthopedic surgeon is included. So some of these patients really suffer. In fact, many times these patients are not even diagnosed. So this is my experience. So I have about 16 patients. A number of them, Charcot in the foot can be considered. Is it something in the midfoot or is it something in the hindfoot? 13 of these had hindfoot Charcot, 2 had midfoot Charcot, and 1 had both. And these are the surgeries that we do. You can either do a nail, which is really a device that we put, an intramedullary device, and that we mainly use it in the hindfoot, where we may do various procedures like a tibial-talocalcaneal fusion. That's the most common. So you may use a plate, and in a plate, we may either use it in the hindfoot, while we may do a tibial-talocalcaneal fusion. That is, we fuse the ankle joint or we fuse the subtalar joint, or you may use it in the midfoot. And sometimes we may do what is known as beaming. And in beaming, basically what we do is we take a large screw and we shove the screw from the metatarsal all the way to the talus. And many a times we use a frame. Now, a frame can be the definitive treatment of Charcot, or a frame can be used in supplementation with either a nail or a plate. So I'll just go through some of these patients that sometimes we see, although I admit that some of them were not all diabetics, but this is really how the diabetics would present. So in this patient, you can see that the patient had got a Charcot. Believe it or not, one of the things that you can tell that a patient has Charcot arthropathy is that when you look at the X-ray, you may see a very dramatic X-ray, like you may see the patient has got a midfoot collapse, or even the talus may be, the ankle may be dislocated, the subtalar joint is dislocated. But when you look at the patient clinically, really they report either there was just a trivial fall or they're not in much pain. And that's part of the disease process. So in this case, what we did, the talus here, I will try and illustrate. The talus here, you can see, is completely avascular. So we removed that talus, and what we did is we shoved a nail. So we did what is known as a tibio-calcaneal fusion. This is another patient with a similar condition, but in this case, unlike the previous case where we used a nail, in this case, we used a plate on the side, and then we put 2 screws there to help fuse the ankle joint. Now, this gentleman, I remember him, he was in his late 50s. He was a type 2 diabetic. You can see he had no previous history of trauma, but you can see obviously that the skin is threatened over there. You can see how destructive the process is. The talus is collapsed there. The ankle is completely, and you may think that this is a fracture, but if you have a diabetic with a fracture after a trivial fall, this is really Charcot until proven otherwise. So what did we do? We went and we debrided the ankle joint over here. We put a frame over there, and that's our frame. And this gentleman is out of a frame. I think he's probably about 3 or so years out, and he's working without any problems at all. This is another patient. She was about 32 years of age. I treated her about 2 years or so ago, and recently I saw a relative of hers in the clinic, and I asked about her. She was from Nyeri, and unfortunately she passed away because of just the sugars and the fact that she had she had renal failure, so she used to go for dialysis. But you can see how completely the subtalar joint is dislocated. So you can see from that AP or from this view, you cannot see the talus, because the tibia really, if you look at this clinical picture here, you can see that the medial malleolus is articulating with the floor. So completely dislocated. So in this case, what did we do? We went ahead and we did two things. Number one, you remember me speaking about using a frame and using a supplemental plate fixation. So that's what we did. Yeah, she did quite well. Eventually, we removed the frame. Unfortunately, she had a periprosthetic fracture, which we managed with a cast. But that, after managing it with a cast, she completely healed until the time of her demise. So what are the results? So really, we've had relatively good results here. Yeah, that these patients have gone, most of them have gone to complete healing. One of them, actually, when I did it, he had a terrible midfoot Charcot, and I did beaming for him. And he got an infection, but that's settled. His foot has settled. However, one of the problems that we have with Charcot is you do find that sometimes it may be in the midfoot, but then again, it progresses to the hindfoot. So in this case, his Charcot has progressed to his hindfoot. Now it involves mainly the ankle. I had counseled him about the possibility of an amputation. We try and avoid amputating these patients because of the amount of comorbidities that they have, and because of the fact that a number of them are quite morbidly obese. So obviously they will not be able to use a prosthesis. He has declined. Unfortunately, I saw him yesterday. He had a trivial fall and sustained a fractured neck of the femur on the left side. So hopefully sometime this week, I will operate on him. But with regards to his midfoot, it has completely healed. So one of the things that we find, medicine is evolving, and sometimes one of the things that we find is that it's very difficult to change practice, because if you've been doing something for so many years and you think it works, it's difficult. So there's been a number of people who have traditionally thought that you could not operate on these patients. And that's the reason why they stick with them. Or sometimes people think that if you refer these patients to surgeons, that we are going to end up just amputating them, which is not the case, okay? So we try and see if we can avoid amputation as much as possible. And what we want really is what determines whether or not we'll operate. If the patient has got a foot that is not plantigrade, we want a foot that can be plantigrade, that the patient can wear a shoe, and preferably not even use a brace. If the patient has got instability, so they're already diabetic, they have a lot of comorbidities and they can't walk. If the patient has got ulceration, then really these are candidates that we should think about doing something in terms of surgery. You can't just continue to manage these patients non-operatively. At least get a surgical opinion. Yeah. And why do we try and do this? One is when you amputate this foot, the contralateral foot is also at risk. You amputate this, you progress to the other. And then also, amputations also have their problems. When you amputate a patient, the metabolic cost of walking increases dramatically, and it's inversely proportional to the level of amputation. So if you do a below-knee amputation, they have a certain metabolic cost of walking. If you do an above-knee amputation, this significantly increases. And therefore, this leads to more cardiovascular demand, more energy demand, pressure on the contralateral foot, which this microtrauma is what may cause Charcot on this foot. So as much as possible, I can tell you, we try and salvage this patient. So when you get these patients, please send them to us and we will try and see. And there are various techniques, like we've said, yeah. One of the things that we use is frames. And this is one of the patients that I did a frame on. And the reason we do this is just because of the fact that They may have infection. They are very osteopenic, and they're also very, very obese. And sometimes we not only do a frame, we supplement a frame with internal fixation. So certain things. Number one, we want to eradicate infection. That is very, very important. Number two, we want a stable fixation. And then number three, we want prolonged weight-bearing protection. That is the reason why we may only use one fixation method, but we may use more than one fixation method. Okay, I think that's it really from the orthopedics. Thank you very much.
Thank you very much. Thank you very much, Dr. Bur. Actually, you've spent about 14 minutes. That's impressive. I think the questions and answers will come at the end. So, ladies and gentlemen, I think we are moving on quite well so far. So Oscar Mwale is in, and Doc, if you are in, and you can be allowed to share your screen.
I yield 1 minute to Oscar Mwale. He was my high school mate.
Okay. Oscar Mwale is a lecturer at the University of Nairobi. He's an ophthalmologist, and this one is hard to pronounce, vitreoretinal surgeon. I think, yeah, fellow Oscar's done again a number.
Doc, it's fine. You can hear me?
I can hear you, Doc.
You can see my screen?
Yes, you can see your screen, Doc. You're welcome.
Great, thanks to Ezekiel. We came all the way from high school together. I just wanted to mention, we tell it the way it is. I like Ezekiel's talk, I like CF Otieno's talk, and Dr. Katambo also. Actually, the last time I listened to Dr. Katambo, after that I had a chapati and I ended up going for confession. I felt so guilty, you know, but that's a story for another day. So moving on, so we're talking about diabetes on the eye. Based at Kenyatta National Hospital. I'm a vitreoretinal surgeon. I deal with the retina and the vitreous there. So, let's see. Okay, so in terms of a bit of epidemiology, it's the commonest cause of blindness in the population of working age in developed countries. I'll give a bit of statistics on our side also, which are available. The prevalence of diabetic retinopathy, which is the most debilitating aspect of diabetes in the eye. The other features that happen, but we tend to focus more on the retina because this is what causes blindness. So the average is 30% with a prevalence of blindness due to diabetic retinopathy at 5. This might look like small figures. Out of 100 diabetic patients, 5 are blind. That is not a small figure. And the other 95 have various degrees of be it visual impairment or be it blindness. So local studies, which range all the way from 2004 to 2018, give us different prevalence rates of diabetic retinopathy amongst diabetics from 17 to 35. Theories are that these are different time periods. And remember, someone could be walking around with raised sugars for a year, 2 years before they actually get into treatment. So by the time they're coming for treatment, they already have diabetic changes in their eyes. Okay, probably the Qualis study, which looked at 650, brought things closer to home. 650 patients between 2016 and 2020, which had 25% of those patients had diabetic retinopathy of various stages. And moving on, so what happens at diabetic retinopathy stage is a microangiopathy, and we're looking at capillary level basically. So we have the arterial, we have the capillary stage there, and we have the venial. So different things are happening. We have platelet thickness due to the hyperglycemic state. We have problems with the pericytes, they die off. These are support structures for the endothelial cells. And we have the RBCs are not easily deformable. So this leads to occlusion, and we end up with circular dilatations at capillary level, what we call microaneurysms. Okay, so all this, you move to the right here, gives you a hypoxic retina at the capillary level, and you end up with production of vascular endothelial growth factor, which is a predominant vasoformative substance. What does VEGF, as we call it, do? You end up with arteriovenous shunts, and you end up with proliferation, abnormal blood vessels forming, which can extend all the way from the retina, which is at the back here, can come all the way to the iris, and you end up with problems of raised eye pressure, which I'll allude to later. Then as you come down here, this is a whole pathology that we see in terms of macular edema, where you have leakage of fluid, you end up with leakage of lipid material, which follow each other, and you end up with fluid and lipids, which give you hard exudates, and this causes swelling at the level of the macula. Remember, the macula is the most central part of the retina, which you use for central vision. So any deformity happening there affects your vision by and large. A couple of risk factors for diabetic retinopathy. First, duration of diabetes, which I believe has been talked about before. I'll allude to that again in a few minutes. Control of diabetes is still important. It does not prevent onset of diabetic retinopathy, but definitely we ask for HbA1c for a reason, because when you control it, you delay, okay? You delay onset, you delay progression, which is a good thing. Hypertension, we all know poorly controlled hypertension leads to worsening of a diabetic retinopathy. Renal disease, pregnancy, the physiological state of pregnancy, we also know if you have mild changes in the retina, when you get expectant, we need to see you more regularly because there's a propensity to change, to progress into worsening forms of retinopathy. Obesity, hyperlipidemia, smoking, anemia, nothing comes out of smoking, by the way, never ever. So all these are risk factors that we know end up with worsening of diabetic retinopathy. And a couple of global figures about duration of diabetes. So as I said, many patients don't know they have been walking around with high sugar, especially in our setup. People tell you, nilikuwa nimeenda choo mara mingi usiku. The last 7-8 months, I used to drink water. By the time they're presenting, you already have eye changes. And in KNH, we have a routine screening process started many years back, where all patients who are newly diagnosed in number 17, MOPC, are referred for eye review immediately, which is a very good thing because we catch many of these cases early. So if you look at key global figures, this is internationally, diabetic for 3 years, 10% already have diabetic retinopathy. 5 years, 23, like that. So as you go, by the time you have 15 years of diabetes, if you look at those who've been diabetic for 15 years, 80% already have features of diabetic retinopathy. Now, what are the features we see? Yeah, moving away from retinopathy slightly. If we can start off with the center, we all remember the cataract should be a clear lens. You end up with those opacities there. Okay, diabetic cataract. Fundoscopy-wise, on the top left-hand side, this is not a normal fundoscopy finding. You see hemorrhages at various levels of the retina, tortuosity of the arterioles and the venules, the disc margin, you can hardly see the optic disc. This is a classical case of central retinal vein occlusion, which is basically a stroke of the eye. It's like a CVA of the eye, cerebrovascular event of the eye, but now we call it a central retinal vein occlusion. This is very common. I already had one case earlier today. We saw this in a diabetic patient. As we move on the right, top right-hand side, you can see the optic disc is pale. It's not supposed to look like, it's supposed to give you an orange pinkish color. So in a case like this, this is the patient who presented painless, poor vision, sudden onset. This is anterior ischemic optic neuropathy. The optic nerve has its own blood supply with the microvasculopathy happening, you end up with ischemia of that optic nerve. Here, I like asking this, if it was a physical venue, when you to ask which is the normal eye, which is the normal eye. Here, the eyelid has to be retracted for you to be able to see the eye. So already there's a ptosis on this eye, on this side, and the eye is turned outwards. So that tells you the lateral rectus is working unopposed. So it means medial rectus, all the levator issues and all are not working properly. So this is a classical case of ophthalmoplegia, okay, leading from cranial nerve 3 palsy. Those are cranial nerve stories now. Okay, so oculomotor palsy presenting as diabetic stories. Now, Dr. Ezekiel Oburu has mentioned the issues of diabetic foot there. Let me not allude to that. In terms of classification of diabetic retinopathy, we can give it broadly into 4. Then you add a 5th one of maculopathy or macular edema. Now, background and pre-proliferative, these two nowadays we mark them as non-proliferative diabetic retinopathy. And you have proliferative where you have abnormal blood vessels growing, and then you have end stage, which can be either a blind eye, which can be painful or non-painful. Then with all this, you can have macular edema. What happens in background? This is mild non-proliferative. We have microaneurysms, which are at the level of the capillaries. We have hard exudates right at the center there, and we have blood hemorrhages. Remember, hemorrhaging on the retina, we have 10 layers of retina. We have 4 venous plexuses within, 4 blood vessel plexuses within the retina. So blood hemorrhages are within the plexiform layers. We have flame-shaped hemorrhages, probably like this one here, which can be at the level of the nerve fiber layer. We have sub-ILM, internal limiting membrane hemorrhages. We have sub-hyaloid hemorrhages. All of this tell us what kind of diabetic retinopathy you have and how advanced it is. So this is background. This looks so horrible, but someone can come to you like this and is having 20/20 or 6/6 vision, looking like this, okay? Diabetic maculopathies are varied. This is one case where you have hard exudates. As I mentioned, lipid material tends to be followed by water. So you end up with edema right at the macular center here. Remember, the macular codes for central vision is what gives you your sharpest visual acuity. The rest of the retina is more of a motion detector. You see something moving, you focus on the side, and you focus with the macula to see the central vision, to see it sharpest. So when you have this kind of picture, definitely your vision is compromised. The closer the exudates are to the center, the more the vision is reduced. And within the diabetic maculopathy, so we talk about diabetic macular edema, is it involved in the center or non-involved in the center? Because the management is slightly different. The other aspects of maculopathy, we have cystoid macular edema, which can come with diabetes. We also have ischemic maculopathy, which can also be part of the macroangiopathy, which ends up with poor vision, and there's nothing much you can do because it's ischemia. There's not much treatment offered for that. Pre-proliferative, this is at the stage now, with the current classification, this is the severe non-proliferative type. And we have various aspects here. This is a flame-shaped hemorrhage. Remember, we said this is of the nerve fiber layer level. We have vascular tortuosity. These are venules. It's not supposed to be tortuous like that. We have microaneurysms all around the macula. Remember, this is the disc. This is the left eye, basically. That's a disc. That's a macular area there. So we have a new aspect here, cotton wool spots, which represent ischemic features at the nerve fiber layer level. So this is quite a sick eye, which if you don't do anything about, patient loses vision. Proliferative, so all those aspects of non-proliferative, mild, moderate, severe, etc. So within proliferative, you can have proliferation at the disc, which we call NVD, neovascularization at the disc. We can have NVE, neovascularization elsewhere. So these are different aspects of elsewhere. Remember I mentioned we have bleeding at different levels. Preretinal can be before, can be sub-ILM, can be in front between the ILM and the rest of the retina, or it can be in front of the ILM behind the vitreous. Okay, so this is an aspect of that. You see a hemorrhage like this, or you see a hemorrhage like this, a boat-shaped type of hemorrhage always tends to be between the retina and the vitreous jelly. You see hemorrhages like this, you automatically go for treatment, whether it's laser injections, etc., which I'll talk about. Treatment must be done. Otherwise, you see this patient 1 week later, he's blind. This is a patient who already had laser. These are all laser marks, but it's still bleeding. But you need to add laser because you notice the laser did not cover very well this particular aspect. What do you get in advanced diabetic eye disease? Nothing is done, patient continues bleeding. The vitreous tends to condense and the bleeds organize in the vitreous. So the vitreous is a very rich surface that has vascular endothelial growth factor, okay? And what happens is you end up with membranes in front of the retina, which lift the retina. So you end up with something called a tractional retinal detachment. We have other types of detachment. You can have exudative, you can have rheumatogenic zones with holes, etc. But in this case, it becomes tractional. It lifts the retina forcefully away from its attachment to the retinopigment epithelium, and you lose vision. And the other thing that happens here is you end up with rubeosis, which is blood vessels forming in front of the iris. Remember, the aqueous moves from the ciliary body behind the iris in front of the iris to the angle where the aqueous drains from. Now, if you have abnormal blood vessels, you see them here, as you see in this picture here, they are definitely more within the angle. So what happens? Your eye pressure goes up. Next thing, neovascular glaucoma, you've lost the eye. End-stage diabetic eye disease, phthisis is basically just a shrunken eyeball, but you have many, you'd hope this to be the end stage. If the eye is so bad and you can't do anything, you end up with end-stage diabetic disease with phthisis. Most of the cases, we don't end up with this. Most of the cases, we end up with painful blind eyes because of neovascular glaucoma. So it's an eye that is not seeing totally blind, but it's paining because it was not taken care of because of advanced diabetic changes. Treatment, what happens with treatment? So laser is one form of treatment that is still done as a gold standard. When you have maculopathy, diabetic maculopathy, you can have laser. These are laser spots here. Though I must say in this example, these are not the best because this energy was too high. Within the macular area, you're not supposed to see laser marks this distinctly, okay? We have other forms. I'll show you a different picture that shows you better laser. And you can have focal. You do it spot by spot by spot, or you can have a grid, a whole pattern of laser spots on the side. Down here, this is the kind of laser we do for proliferative diabetic retinopathy. Now, by the time you're doing this kind of laser, yes, it stops the bleeding. You notice the blood vessels get attenuated, very much thinning. So it tells you already, you're not talking about 20/20 vision in an eye like this. Definitely you'll not get 20/20. So two aspects happen. You lose night vision, or you end up with issues of night vision, because remember, this is where the roads are concentrated on the side. And secondly, you have a constricted visual field, so you tend to see mainly in the center. This is someone who, if they're driving, they keep hitting those borders on the side, or they're walking, they're knocking people on the side, and people think this is a very rude person. This guy is not basically, his visual fields have been constricted by the laser due to diabetic eye disease. So this is more on the macular kind of lasers we do. This is a grid which is done with this particular pattern. We tend to minimize doing laser within the macula, center of the macula and the disc, because the papillomacular bundle lies here. So most of the laser is on the side. But nevertheless, nowadays we have newer machines which give you sub-threshold laser, or we call it micropulse laser. So the spots are not this obvious, and it's more comforting to the eye, more gentle, more forgiving to the structures of the photoreceptors, etc., so that you end up doing central laser without causing scarring significantly. So they're just different aspects of laser we're talking about here, okay? But the laser helps in sealing the leakage and gives you some vision. Many times I'm not talking about 20/20 vision in this kind of eyes. You want just the patient to have something that they can function with. Now, second form of treatment, so we have laser, then second form, we have antivascular endothelial growth factors. Now, there are several we talk about here. We inject this into the eye, directly into the vitreous cavity. It's the most common eye procedure done all over the world right now for diabetes and other retinal conditions. So we have drugs like aflibercept, which is by Bayer. We have bevacizumab by Roche, ranibizumab by Novartis. They are all effective, and many studies have been done comparing this and this vis-a-vis what kind of vision they're starting with, etc. And yeah, they're available. All these are available in Kenya right now. Just to move on now, we have a trial, clinical trial we're just about to commence, taken us about a year. For the first time, actually, I believe in ophthalmology history, we'll be having our own clinical trial, our own arm within Africa. We have 2 study sites in Kenya, which are the only study sites in Africa, actually, where we'll be using a new drug called faricimab. This is by Roche Genentech, which we will be looking at the effect of a drug that is both anti-VEGF and anti-angiopoietin-2 pathway. And it's been registered already in the US by the FDA, but in our setup, we're part of a huge study between us, parts of Europe, different parts of US, and even I think there are 2 centers in India. We'll be having our own data for once, instead of quoting the Mzungu figures as it were, and this will be a very good thing to have. Moving on, we also have steroids that we use in diabetic macular edema. And steroids have the anti-inflammatory component. The only downside of steroids is...
You have 3 minutes plus Dr. Buru's 1 minute for.
Thank you. The only downside of steroids are they produce, they stimulate cataract progression, and they also end up with raised intraocular pressure. So by the time you're using it, there are certain patients you can use it, certain patients may not use it. Okay, now I have a slide flowchart here. If I can go back a bit, we have, triamcinolone is known by all canalog. This is not meant for the eye ideally, but if it's the only thing you have, you can still use it. Dexamethasone and fluocinolone acetonide are the ones that used that are made specifically for the eye, but they come at a cost. Ozurdex is about 60,000 or so. Reticet and all this about 800,000 shillings if someone can afford. So you can see many times we end up giving triamcinolone. Cheap, it works. This is a flow chart. Whether the macular edema is center or non-center involving, that's how we determine what kind of treatment to give, where the patient is coming from, how regular can they come, etc. Now, I have a short video here, which is my 3 minutes, just to tell you what diabetic vitrectomy looks like. I think this is just from the YouTube. Get into that. Next. You can see this is not a normal retina, so many visions happening. You have to relieve the vitreous. From the visions, you have bleeding in certain areas, like at the back. Patients present like this every other day in the teaching hospital at UoN-KNH National Hospital. So this is the standard vitrectomy we do for diabetes. Okay, so you the blade to have access to the retina so that you can. A bit. So here we are. Okay, we are still relieving traction areas within the retina. This is at the optic disc. This is the macular area. I mean, it's quite a lot of work. There's always a risk of bleeding during the surgery. If only we pick these patients early, we will have this. And at the same time, patient compliance is an issue. We have patients who may not come on time in spite of being told to come back. These are some of the factors you consider when you're deciding what treatment you're going to get. But go on again, some are there. We're still relieving traction at the vitreous. Traction at the optic disc, sorry. We're using that for retracting the forceps. Nowadays, we have switcherless vitrectomy now. We don't stitch the sclera in. Those 3 ports is so created, we don't stitch anymore. They're about 0 millimeters. So getting out of the right the eye. For this, we do laser. Okay, still clearing clots, etc. This is what laser looks like. Okay, in the eye. With this is a form of laser we call endolaser. We have a probe that goes into the eye, and we laser all around. What does a laser do? It reduces the drive, okay, and they end up with a more retinal reduced chance of bleeding. Looks very traumatic, and but that is what you have to do to save this eye. Okay? Reduce visual field, etc. Okay. I think I can stop there. Okay, after that video, I got stuck a bit over there. Now, the screening in terms of retinopathy, if we see you don't have any retinopathy features, or you have what is called mild non-proliferative, we can see you yearly. If you're someone reliable, we tell you if you notice any change, you come earlier, or sooner if your vision deteriorates. Okay, so not everybody who comes to us from number 17 is put on treatment. It depends, what we find depends, profession depends where the patient is coming from. All the rest, whenever I'm not sure, I know there are people who also do direct ophthalmoscopy, etc. If you're not sure of anything, we always say this one, you don't patch and refer, just refer to the ophthalmologist. I know the teaching is patch and refer. Just refer to us and we will see what to do. And we always communicate back with our colleagues from internal medicine on what we find when you send us these patients. With that, thank you very much. And it was a great opportunity to share this with everyone here. Thank you.
Thank you very much, Doc, for at least keeping time. I don't know whether Dr. Alfred Sotti is with us. Okay, if Dr. Alfred Sotti is not with us, then Dr. Muli.
I'm here.
Oh, yes, Doc.
Yes, I'm just waiting to be allowed to share my screen. Just give me a minute, please.
Yeah, Dr. Sotti is a senior lecturer at the Department of Obstetrics and Gynecology at the University of Nairobi and an affiliate associate professor at the Department of Global Health, University of Washington. He holds an MB-CHB, Master of Medicine in Obs-Gyn at the University of Nairobi, as well as an MPH and PhD from the University of Washington. His area of interest is maternal-fetal medicine. He's a researcher and has supervised more than 20 postgraduate students and published more than 40 peer-reviewed publications. He's a PI or co-PI in multiple NIH and WHO-supported studies. His research interests are maternal health, cardiovascular, and cardiometabolic disease risk after pregnancy. Welcome, Dr. Sotti. Again, we are going to hear from the best in terms of diabetic in pregnancy. Karibu, Doc.
Okay, thank you very much. Can you hear me?
Yes, Doc, we can hear you very clearly. And
Okay,
we can see your
okay.
slides
So
as well.
my talk is on diabetes in pregnancy as part of this NCD new pandemic challenges and innovations in management. I'll review briefly the burden, a bit of classification. We may talk about pathophysiology if we have time, adverse outcomes of diabetes in pregnancy, then the care we provide during pregnancy, long-term outcomes, and some of the challenges in prevention, screening, care, and follow-up, and maybe highlight some of the innovations or interventions we can put in place for the same. I noticed that some of these have already been mentioned, so I'll move over them pretty quickly, and I'm grateful for the first speaker and Professor C.F. Otieno for highlighting some of this. So diabetes is a burden. As a 2021 estimates by the IDF, about 500 million people are estimated to have an equivalent number is thought to have glucose intolerance, but not meeting the criteria for diagnosis of diabetes. Last year, they estimated about 6.7 million deaths. And for the first time, they recorded the number of children and adolescents affected by type 1 diabetes as 1.2 million. The graph on the right gives us an estimate of the global prevalence of diabetes in 20 to 79-year-old age groups. And as you can see, it is continuing to grow alarmingly, especially in lower and middle income countries. So we need to do something about it. Important to know that about 240 million people who have diabetes are undiagnosed. Okay, so it means that the numbers that we have may be an underestimate. And majority of those who are undiagnosed live in low and middle income countries of Africa, Southeast Asia, and the Western Pacific. This image had been shown by the first speaker, showing that Africa is having a higher increase, even though globally the increase is 46%, but in Africa it's more than 3 times that, 134%. And there are many factors that have been highlighted by the previous speakers that contribute to this. Now, what about diabetes in women and in pregnancy in particular? So it was estimated as a 2019-2020 data that more than 200 million women actually had diabetes. And it's estimated this number would increase to 343 by 2045, again showing that this is something that's increasing alarmingly in our population and interventions are required. Okay, diabetes in pregnancy affect 1 in 6 births, and mostly it's gestational diabetes, and majority of these are in lower and middle income countries. So because GDM or gestational diabetes is the main type of diabetes we have in pregnancy, we'll spend a bit more time talking about it rather than the pre-gestational diabetes. So how do we classify diabetes in pregnancy? The main classification is whether it occurred before pregnancy or during pregnancy. So if it occurred during pregnancy, we call it gestational diabetes. It can be type A1 or A2. A1 means these are fairly stable. After making the diagnosis on diet and exercise, they are well controlled. If they require more than that, they need medicine beyond diet and exercise, then this is now A2, okay? Then pre-gestational, as we already know, can either be type 1 or type 2. They may have or may not have vascular complications. And then we have diabetes from other causes, like the genetic syndromes, pancreatic disease, or those who are on drugs or who have chemically induced diabetes. So this is the broad classification that we use. But in simple terms, you can just say it's pre-gestational or gestational. So pre-gestational is that before pregnancy, and gestational is that which is diagnosed during pregnancy. So that's basically what the next slide describes. That is diabetes that is first diagnosed in the 2nd or 3rd trimester of pregnancy, that is not clearly either pre-existing type 1 or type 2 diabetes, is what we call gestational diabetes, okay? So what is the burden of gestational diabetes in sub-Saharan Africa where we are, okay? You can look at several studies that have been done, including systematic reviews and meta-analysis, and you get a prevalence of between 7 to as high as 20%, okay, depending on how the studies were conducted and where the populations were, where they were conducted. So it's a small, not a small problem as you'd think, okay, as many people think. So it means that the burden is high in pregnancy, and we need to ensure that we make appropriate diagnosis so that we can manage these patients well. So you may ask yourself, do we have any numbers for Kenya? Yes, we do. We conducted a study with Dr. Suha, myself, and other investigators in our department, and we estimated the prevalence of gestational diabetes to between 23 to 24%, depending on which approach you had. If you just use as challenge test, you would get 24%, and if you performed an OGTT, you'd get 23%. So basically giving us the same prevalence. So 2 out of 10 having diabetes in your setup means that is a big problem that you need to think seriously about and manage appropriately. So quickly about the pathophysiology, early pregnancy, we have increased insulin sensitivity, and in late pregnancy, we have increased insulin resistance. And the increased insulin resistance is mainly because of hormonal factors, okay? And because of these changes in hormone levels, you have high maternal glucose levels, high levels of fetal glucose as a result, which results in stimulation of the pancreas to produce more insulin. So there's hypertrophy and hyperplasia of the pancreatic beta cells to respond to this as far as the fetus is concerned. So if this happens in pregnancy, then it puts women at risk of developing gestational diabetes. Recent studies show that gut microbiomes may also play a role, and that is why things like diet and use of probiotics have been thought to contribute positively to the reversal, as the first speaker mentioned, the reversal of diabetes, type 2 diabetes, and also diabetes that follows pregnancy. So changes in some of the microbiomes, like the reduction in firmicutes or increase in prevotylation, may increase the risk of developing diabetes. Other things like oxidative stress and placental transport changes may also result in gestational diabetes or its sequelae. Okay, so why are we worried about gestational diabetes? Because of its complications. In early pregnancy, especially if they have pregestational, may get spontaneous miscarriage, but later may get preeclampsia, gestational hypertension, large babies, polyhydramnios, urinary tract infections. When they have these complications, again, later they can deliver prematurely, preterm birth. Big babies can be traumatized at the time of delivery, resulting in nerve injury or even limb injuries. Assisted vaginal or instrumental deliveries are likely to occur, cesarean section, postpartum hemorrhage, sepsis, okay, and increased risk of maternal morbidity and mortality. In the postpartum period, they can have challenges with lactation. So some of them may even have lactation failure, sepsis, they have increased risk of infection. But then in the long term also, they have increased risk of weight retention and gain, subsequent gestational diabetes in subsequent pregnancies. They are more likely to get type 2 diabetes, and that's why interventions for reversal are necessary in these patients. And they are also, it's very important to note that they are also at high risk of developing future cardiovascular disease and cardiometabolic disease, okay? They are also likely to have neonatal death, congenital anomalies, respiratory distress syndrome, cardiomyopathy, low glucose levels, that is their neonates, and long-term, these babies may also have programming, imprinting, fetal origins of diabetes, hypertension, or metabolic syndrome. I've rushed over that, but basically what we are trying to say is that not only the mothers that are affected, but the children are also likely to be affected in the long term. So the interventions that we offer during pregnancy is not only beneficial to the mother and the neonate, but also important for these children as they grow up. In fact, studies following them up into adolescence have shown that they have also risk of this cardiovascular disease and cardiometabolic disease, okay? And that's basically the long-term complications we are talking about: diabetes, cardiovascular disease, obesity, and even poor neurodevelopmental outcome, okay? So what do we do then? What should we do to try and lower the risk of these complications in gestational diabetes, okay? So we must offer universal screening, and this is a challenge even in our setup. We are not offering a universal screening for all women at 24 to 28 weeks, okay? If the women have risk factors which we have listed below, which are basically risk factors for diabetes, then you must offer screening as early as possible, okay, when you see them in pregnancy. If the results are normal, then you still have to screen them at 24 to 28 weeks. And the risk factors for diabetes are many that we've talked about. So obesity, previous diabetes in pregnancy, high BMI, okay, hypertension, physical inactivity, or if they have had large babies in the past. These are straightforward things that we can look at a little bit later. So how do we screen? There are two approaches to screening, and this may also be a challenge in our setup. So the two-step approach is where women come into the clinic, you give them 50 grams of glucose, that's called a glucose challenge test, and then you check their blood sugar in 1 hour, okay? If they screen positive, then you move to the second step where you give them, depending on the protocol, 100 or 75 grams of glucose, and then check their blood sugar 2 to 3 hours later, okay? The one-step approach omits that screening of 50 grams. So you just give them 75 grams of glucose after fasting, and then you do a 2-hour glucose test. So you check the blood sugar after 1 hour and after 2 hours. And this requires an overnight fast. Now, the challenge with this is that some of the patients, when they're advised to come, they won't come, okay? And then they would present later with complications. Now, the advantage of the two-step is that because there's no restriction regarding meals, you can actually do the screening test, okay? Immediately you see the patient in the clinic, okay? And this is basically summarizing the two. So the preferred approach is to do the 2 steps, okay? And with cutoffs that are established, you are able to arrive at a diagnosis of gestational diabetes, okay? If you do not do that, you just go to the alternative approach where you give 75 grams. And if you meet the cutoffs, then again, you can make the diagnosis of gestational diabetes. So these are the 2 approaches that are recommended, okay? Now, some of us may ask why these 2 approaches and what's the differences between the 2, apart from what I've explained.
3 more minutes. 3 more
Sorry?
minutes. You have 3 more minutes.
Sorry?
You have 3 more minutes.
3 more minutes, okay. So if you have a one-step approach, then you'll have a higher prevalence, okay? If you have 2-step approach, then you may have a lower prevalence, okay? So the management is glucose control, prevent preeclampsia, follow them up very closely, evaluate for complications, give DVT prophylaxis, and do ultrasound as required, okay? So I'll escape that and just move to the challenges, okay? So the challenges that we have are in preconception care and counseling, okay? It's very important to know if your patients have diabetes before pregnancy, but unfortunately, most of our patients do not come for preconception care because, as Professor CF had mentioned, the infrastructure does not support it at all. If you want to go for preconception care today in a county hospital, where do you even start from? There's no clinic labeled for preconception care. Screening and diagnosis, some people do not know the protocols, and even if they do not know the protocols, they send patients for an OGTT, which is not done every day. So patients come and they're told, come another day. And we know what happens in our setup. If you do that, patients would not come back. Glycemic control requires nutrition, drugs, and monitoring. Sometimes getting the drugs is a problem. And sometimes even getting the glucose strips to monitor the blood sugars is a problem. Comorbidities require multidisciplinary care, which may not be widely available. And then there's neglect of the postpartum care. Okay, so most women, when they deliver, they don't come back to the clinic, or when they come back, we don't concentrate on their sugar control. And then there's no long-term follow-up for the mother, the neonate, or the child. And more importantly, we have incomplete guidelines that do not exactly tell our clinical care providers what to do for these patients during screening and what to do for them during follow-up. And of course, there are situations where the training may also be inadequate. So this slide tells us that even in high-income countries, despite people knowing about preconception counseling, less than 40% would offer preconception counseling. So we need to improve on that, and our institutions should be able to give women an opportunity to get preconception care. Now, what about glycemic control? One of our residents looked at the glycemic control among women of productive age group at Kenyatta, and up to 42%, only 42% had good control. More than half had poor control. Now, if these women conceive, definitely they will get complications. So we need to work with our endocrinologists to improve glycemic control in our women, okay? We have to choose the appropriate test for our setup, whether it's 1-step or 2-step approach, and I've given the benefits of one or the other. Most studies from North America support the 2-step approach. The WHO and Europe tend to use the 1-step approach. There are challenges with the 1-step, and that's why some of us recommend the 2-step approach instead of the 1-step approach to see whether we will screen more women, okay? In terms of blood sugar control, poor control is a problem, but use of metformin versus okay. Has also been associated with more adverse outcomes with metformin in preliminary studies, not all studies. So this is something that is an area for follow-up, okay? This is just to highlight that gestational diabetes is one of the risk factors, together with other components of adverse pregnancy outcomes on cardiovascular risk, and we need to follow these women carefully so that we reduce their cardiovascular risk, okay? The same is emphasized here, okay? And lastly, this is the last slide. So how do we mitigate the cardiovascular risk and cardiometabolic disease risk after adverse pregnancy outcomes? So early postpartum care is very important, and it has to be comprehensive and structured. We need to have transitional clinics where we take care of these women as we transfer them to the multidisciplinary endocrinology care. We need to ensure we have comprehensive lifestyle modification, which the first speaker talked about regarding reversal. Breastfeeding also helps with control, and we need to try some of the interventions that can reduce the risk of diabetes, type 2 diabetes after gestational diabetes, like use of metformin. And lastly, and very important, let's educate our patients, let's educate our clinical providers so that we know how to take care of these women pre-conception, during pregnancy, and in the postpartum period. Thank you.
Thank you very much, Dr. Soti, for that clear information. Ladies and gentlemen, without much ado, I would like to invite Dr. Tony Muli to give us his presentation on oral health in diabetes. Dr. Muli can share your screen. He's a specialist periodontist and dental implantologist and a senior lecturer unit of periodontology in the Department of Dental Sciences at the University of Nairobi. Dr. Muli is very well read, sits in several international dental editorial boards. Some of his academic qualifications, of course, is dental surgery, Masters of Clinical Dentistry at the University of Nairobi and the Queen of Mary University in London. Has a PhD in periodontology at the King's College London. His research interests are in salivary biomarkers and the interrelationship between oral health and general health. Welcome, Doc.
Well, thank you very much. I hope I'll be able to share this screen as soon as possible. I don't know whether you can see that.
No, we still can't see your screen.
Okay. Let me exit that again quick and then see whether it will come up.
Okay, yes, Doc, now we can see your screen.
You can see that? Okay, great. Yes. So let me activate it. I see whether it will do what it's supposed to do. You can see that?
Yes, yes.
I'm not sure whether you can see it when it is moving to the next slide.
Try.
So it seems like it's not.
Yes, it's moving. It's moving. We are now on slide number 3.
Yeah, well, it's the thing that it's not showing when I do the full.
Yeah, I think this was okay. This
let me do the share again like that, and I see whether it will play.
Ladies and gentlemen, just bear with us. I know we are running short of time, but I think the two remaining.
Yeah, so I think what I do is I'll just play it straight from the slides as though I'm editing it, just like that, and we'll have to bear with it like that. No, we won't be able to see the full screen. So I hope you can see everything. As I said, Doc said, I'm Tony. You can call me Muli with a double L. So, and I'm here just to represent guys who are in the oral health. And As a lecturer, I would like my participants to know that at the end, they should be able to know the adverse effects of diabetes on periodontal health and the role of periodontal infection in adversely affecting glycemic control, the impact of periodontal therapy on improving glycemic control, and lastly, the relationship of periodontal infection to the risk for developing diabetes complications and possibly diabetes itself. So please just remember that the mouth is not on a tree. There is lots of times in the healthcare profession, the mouth seems to be somewhere outside the body, the human body. So please remember the mouth is in the human body. And you need the mouth for many, many reasons. For example, sensory analysis of the stuff that you swallow, that you really like, everything that you like, whether it's liquid, whether it's solid, mechanical processing of tea or food and lubrication of food, etc. You know, we have some limited digestion as well of lipids and carbohydrates, and very serious other functions like social functions. For example, you can remember the last kiss you had and the food that you ate in a social setting, and many other ways that the mouth is very, very critical. And so really, that interview you did to get the job, you needed the mouth, etc. So no mouth, no deals, and then no deals, no meals, and no meals, no smiles, and many other issues. You start finding that this mouth can be related to many other parts of the human body. So basically, that's what I want to bring us to speed, that you know that the mouth is a critical part of the human body. Okay, so if you look at, if we're trying to look for reasons why the mouth might be associated, we know that if the sugar level is high in your blood, as in diabetes, it's also high in your saliva too. And then the bacteria will use that sugar to thrive, and that can lead to tooth decay, cavities, and gum disease. And of course, if the teeth are not treated or the gum disease is not treated, then you have tooth loss. And there's a tendency that people who have either weak teeth or other dental diseases, they tend to choose soft foods, which if you know, most of them are carbohydrates, which then feed into the cycle of diabetes and all those other metabolic conditions. So it's important to take care of the mouth. Now, we are focusing more on gum disease because it is more like any other infection in the human body. Gum disease technically is called periodontal disease. In a condition we call periodontitis, for example, and is a destructive inflammatory infection of the tooth supporting structures. And so if you look at these tooth supporting structures, they include both soft tissue, which has both the epithelium, connective tissue, and he also has the hard tissues like the alveolar bone, the cementum, and then we also have the periodontal ligament. And so if there's an infection and an inflammatory process that is going to take place in epithelium, connective tissue, and hard tissues, then you can see how easily it can relate to other aspects of the human body. So the microbiological challenge that these plaque bacteria give to the body then stimulates a whole disease. And you can see this is the cycle. You have the gums, which are healthy. I hope my mouse can be seen. You can see the gums are covering the roots. You can't see any part of the root, but as inflammation, once this plaque biofilm builds up, then you start getting the soft tissue inflammation, and which then sends signals, and you start getting bone destruction, leading to actually tooth loss when the disease is very advanced. Now, the sad story is that over 90% of the Kenyan population has periodontal disease in one form or the other. And 10% of these have actually the advanced periodontal disease. And I'm sure you have seen in the population, as people get to be 50 years and above, even amongst ourselves, they start having very long looking like teeth starting to spread, getting spaces between itchy gums, bleeding gums. You've seen people losing teeth. All that is not an aspect of aging. It's actually a preventable disease called periodontitis. And is periodontal disease any dangerous? Yes, there was a study done among the Pima Indians who are above 35 years old. And they were looking at the relationship between diabetes and periodontal disease. And they found that about 3.7 deaths per 1,000 persons, was noted among those who had no periodontal disease or had very mild disease that you could easily ignore. But then 19.6%, there were about 19.6 deaths per 1,000 in those with moderate disease. And then this number increased to 28.4% with those who have severe disease. And we are talking about severe disease in about 10% of the people who have periodontal disease in this country, and 90% of the population has periodontal disease. So you can see what we are talking about. Now, this relationship was even significant, even after adjusting for numerous other confounding factors, such as smoking, etc. So what we are seeing is, in short, is that there's a vicious cycle between gum disease and diabetes. It's a two-way street, really. Yeah, that if you have gum disease, then there is a tendency to have other conditions such as diabetes, and with diabetes, it becomes a little tricky, and you start getting gum disease. Now, in a simplistic way, you can see here that those who have diabetes are 2 to 4 times more susceptible to gum disease. Okay, and then the gum disease itself then decreases blood glucose control and increases insulin resistance and hyperglycemia. Now, then that, of course, affecting the microbiota in the mouth, etc. Then and other things like white blood cells, etc., which get affected, it becomes the person becomes more prone to gum disease. So really, that is the trap that people get into. Maybe a little more detail, you start seeing with periodontitis, then there's dysregulated inflammatory responses with pro-inflammatory cytokines and matrix metalloproteinases, which then get increased, and these have a way of increasing hyperglycemia. And then, of course, diabetes, the relationship, as other colleagues have talked about, with obesity and all that, with adipose tissue producing adipokines, ages and rages and stuff like that. All these interact, leading back to this dysregulated inflammatory response, and then leading to periodontitis. And you can see there are other things like smoking, which is a lifestyle issue, which tends to also happen in people with diabetes, and also severely affects periodontitis. So all this mix here then makes the two diseases very bad. Now, maybe a more complicated interaction here. You can see cytokines like interleukin-1 beta, TNF-alpha, IL-6, all that get hyper, and then they affect the liver, getting this production of C-reacting proteins, all these stuff, and all that feeds back into diabetes, and then that feeds back through apoptosis, defective neutrophils, etc., with the poor, the lazy leukocyte syndrome, chemotaxis problem. Then that leads to gum disease, and then the gum disease feeds back over and over again. So, and the end results, of course, you get diabetes complications, etc. So I think this is just to make an impression that these different parts of the body are interrelated. So the mouth and the rest of the body are linked. And so if you look at this, there's a web of trouble here with gum disease leading, in other studies, has been shown to be associated with cardiovascular events such as stroke, heart disease, Alzheimer's disease, because of, like, for example, this microorganism, the P. gingivalis, which produces a toxic protease called gingipain, etc. And it's able to pass the blood-brain barrier and things like that. And so people have associated it with Alzheimer's disease. Yeah, of course, we talked about uncontrolled diabetes. Even in the age of COVID, I remember reviewing a paper recently And it was evident that people who had periodontitis were more prone to respiratory infection with COVID. So, and all these other aspects, yeah, preterm birth weights and stuff like that has been shown. So in short, I didn't want to make this very long. Is that that's the star story with a silver lining, that actually, if you treat it, because gum disease is very easy to treat, you just need to visit your dentist every 6 months, and they can clean this stuff, which no matter how good you are with brushing, this stuff will build up anyway. It's called tartar in normal language, but calculus, which is basically the microbial biofilm, which gets mineralized because of the supersaturation with calcium, phosphates, and things like that in the saliva. So it gets mineralized, and this becomes an ecosystem for the microorganisms to breed and cause this inflammatory response in this area. And that can be easily removed, and then it becomes easier for the person to brush and keep this biofilm level at a minimum that then helps with the health of the tissue. And of course, then the benefits keep spreading to the other areas. So we are talking about non-surgical periodontal therapy improves glycemic control, particularly in type 2 diabetes, with an average reduction of HbA1c approximately of 0.4%. And you'd say 0.4%, is that anything? Yes, because improvement of that 1% reduction in this is usually a 14 to 21% reduction in diabetes-related endpoints, okay? So as I conclude, I say, then what is the role of dentists? In University of Columbia, some researchers evaluated the number of missing teeth and the percentage of deep periodontal pockets, which are like the cardinal signs of destructive periodontitis. They were able to correctly identify 73% of cases with diabetes and pre-diabetes, okay? And what we have noticed is that a lot of times is the dentist who gets to see these kind of periodontal abscesses first. The patient comes complaining of these abscesses, loose teeth, and etc. And a lot of times they just say, okay, fine, can you go have your sugars checked? And voila, a lot of times you find the patient was pre-diabetic or was actually diabetic. And that's usually the first contact or with a doctor who then identifies that there is potentially this problem of diabetes. So I think dentists need to continue playing that role carefully. So what would you say then to other healthcare professionals, like the doctors, the physicians, the clinical officers, etc., is that they should always require their diabetic patients to visit their dentist. And the recommended time is always 6 months, because a lot of stuff, whether you're good at brushing or not,
Doc,
a lot of
2 minutes
on this teeth. And so it is important that they have that checkup. So in conclusion, gum disease can be more severe and take longer to heal in those with diabetes. And if one has gum disease, their diabetes may be harder to manage. So basically just pleading that you need to bring back the mouth into the body, and that multidisciplinary approach in managing patients with periodontal disease and diabetes, as well as other non-communicable diseases, should be the norm. I would really highly recommend that you look at this paper published in the New York Academy of Science, Annals of New York Academy of Science in 2012 on diabetes and oral disease, the implications for health professionals. It will be a very nice thing. You can take a screenshot or a photo or something and just read that and help us that we may bring the mouth back into the body. So thank you very much, and have a nice evening.
Thank you very much, Doc, for keeping time. Actually, we spent exactly 15 minutes. That's impressive, and a very clear presentation. So with last but not least, ladies and gentlemen, and I really thank you for your patience. Let's invite Prof. Prof. Judith Waudo. Please, Prof, you can mount your slide. Prof is a full professor of nutrition at the Kenyatta University, with an area of expertise in nutrition education. She's a faculty member in the Department of Foods, Nutrition and Dietetics at the Kenyatta University. Over 37 years of teaching and research in nutrition. And note that she has also she has taught and of course mentored many postgraduate students in nutrition. So Prof, welcome about diet and lifestyle in adolescents and youth.
Thank you very much. Mine won't be too much because some of the speakers have already alluded to what I'm going to talk about. But basically my topic for today is diet and lifestyle in adolescents and youth. Next slide. Next slide. So my presentation will just touch a little bit on risk factors, challenges, which have been also alluded to, influences on adolescent eating behavior, key messages, prevention in terms of nutritional interventions, and then of course recommendations. So I won't be long, mine will be short. Next slide. This presentation, I just wanted to bring to our attention that the relationship between adolescent diet and chronic diseases is based on the assumption that eating behaviors are learned and are solidified during childhood and adolescence. Therefore, these behaviors are held in adulthood and are very difficult to change, even with the diagnosis of these chronic diseases. So it is very important for us and for the patients we work with to be able to maintain good nutrition during childhood and adolescence. Next. Next slide, please. Right, it's gone, but I will continue as they are putting the slide on. Next slide. And now, in terms of risk factors for diabetes among adolescents, again, this has been alluded to earlier on, but first is obesity, basically with a BM of 30 and above, is a risk factor. Again, number 2, impaired glucose tolerance, polycystic ovary syndromes, exposure to diabetes in utero, and hypertension and dyslipidemia. Again, this has been alluded before. Next. Now, what are some of the challenges for adolescents, diet and nutrition? First, again, when you look at them, whether they are any diabetes or any other chronic diseases, we are talking about the eating choices. As you have seen earlier on, is the most difficult thing is the fast foods. These are actually a common diet for these adolescents, whether they are diagnosed with diabetes or not. We are also finding cases of very refined food and large quantities of carbohydrates, which are not actually good for the persons with the diabetes. We are also noting among, again, research has shown a limited nutrition information for adolescents and early childhood. And we are hoping with the CBC that can be actually be promoted. But we are seeing that is currently is a challenge. Of course, again, this has been alluded earlier on, that we are seeing poverty, especially in the rural areas, is also a deterrent. We are also seeing a culture among the adolescents of many of them eating away from home. And those foods that are eaten from home, many of them have very high calories. And some of them are street foods, which are also using a lot of calories in the preparation of that. Again, among the adolescents, what we are seeing as a challenge is inactivity or lack of exercise. And again, we are also experiencing techno craze or increased screen time, especially with the social media. So these are some of the challenges in the adolescence or early childhood in terms of managing of diabetes. Next. Again, we see a lot of influences on adolescent eating behavior. Again, as we saw from the first presentation, the psychosocial in terms of food preferences. This is actually a key determinant in terms of adolescent health. Then, of course, we see the biological a need for that, the food, and again, depending on the stage they are at adolescence, again, that would affect their intake. We are also seeing a bit of cultural attributes in terms of food intake. Even if there is a prescribed or a prescription from our medics, they actually go back to their cultural food habits. Again, we are seeing a lot of lifestyle changes in terms of mortality and the 20 foods. Again, we are seeing adolescents, whether they are sick or not sick, they're actually going to that particular 20 foods. Again, we are seeing a lot of peer pressure, putting a lot of impact on what they are consuming, and in terms of their observance, in terms of what is recommended. Again, we are also seeing family influence in terms of what is acceptable and what is not, and this comes up from very early age. Again, we are seeing advertisement. In fact, if we are quoting the research, actually 70% of the intake among adolescents is actually influenced by what is being advertised, on TV or on the social media. Again, technology, many of the youth, even the ones who are actually with diabetes, they are looking at to see what is trending, what can we be able to make from looking at the Google, and finding out what is easier for them to make, Yeah, so again, being just innovative, trying to try new things. Again, this is actually affecting their intake. Next. Right, now, what are some of the key messages we are seeing that at the age of 10, we are finding about 3 million or 3% of the children at that age, they face diabetes or hypertensive risk. We are also seeing a lot of physical inactivity, which I'm calling silent epidemic. Again, with the issue of the technology grave, they are not able to do anything else apart from just the social media. We are also seeing a lot of unhealthy food, especially among the school goers, and of course the issue of vending machine playing a key role in terms of what they are supposed to take. Again, within the school system, we are finding low coverage within urban areas and also rural areas. But again, these foods, when you look at them, they are more of high carbohydrates and also what the so-called teenagers would prefer to have. Next. Next slide. Now, what are some of the prevention that we are seeing in terms of these adolescents and school going age? We are saying again, in terms of nutrition, from very early age, which we usually encourage exclusive breastfeeding, we believe it is a key instrument in terms of prevention of these chronic diseases, especially diabetes. We are also saying that with the maintenance of a healthy lifestyle, if they have a good lifestyle from the very beginning, when they reach adolescence, they should be able to continue with that healthy lifestyle. Again, that is key for them to be able to prevent them in terms of getting those chronic diseases. And we are also saying that the family-based behavior intervention are key component. Again, the way they have been brought up, the way they have been socialized, the way they interact with the other outside community is going to be a good influence for them. We are also advocating for moderate daily exercise. And this is a problem because when you look at schools, especially in urban schools, where there are no even facilities for these physical activities, these children are not able to undertake that, and yet it's an important component for them. Thus, we are advocating for the promotion of physical exercise in schools. And again, when you look at urban areas, we are seeing lots of vending machines or food vendors across the different school sites. Again, here we are recommending the removal of the food vendors around the school sites. Next. In terms of nutrition intervention, again, we are promoting the consumption of health diets from early childhood, which I've said before. And as I said before, the current CBC system is trying to actually advocate that, so that the student at the P1 primary education is able to actually to know what is required for them. So as they grow up and they get these diseases, they're able to manage those diseases in a way. Of course, we are promoting the promotion of nutrition education in schools. Again, that is could be a highlight for that, so that they're able to know, have the information, they're able to use that information to practice in their daily living. We are also advocating the use of development appropriate strategies that are different needs for each, for boys and girls at different stages as they progress during their life cycle. And of course, the inclusion of nutritional foods and high fiber diet, because those are actually healthy and are able to actually make them manage their disease condition. And of course, we are advocating the use or the sufficient amount of water, at least 10 liters per day. Getting to the research, actually, the adolescents, they don't take much water. They will take a bit of those sugary beverage, but water is very limited in terms of what they take per day. In fact, the average is about 2 to 3 liters a day, which is way very low in a way. Next. Major challenges we have seen in the management of diet among the diabetic patients, especially adolescents. We are experiencing that they have what we call non-adherent to the strict diet, that one that has been prescribed. So they are not able to stick to that. The other issue we are experiencing is the adherent to own prescribed diet. Again, because of that stage, they want to actually decide what to eat in spite of their disease condition. So they continue violating what is prescribed to them. Of course, the issue of affordability of treatment or diet is also a key factor, which has been proven in several studies. And of course, at that adolescent stage, there's the rebellious in terms of, good nutrition advice. So they think they know it all, and so they don't actually observe what is actually being recommended to them. Next. Now, what are we recommending? So adolescents should receive guidance on the following. First, we are promoting the healthy eating. Number two, we are limiting the sugar, the intake of limited of sweetened beverages. We are also limiting the screen time for the adolescents. We are also decreasing the sedentary behavior and increasing both the light and vigorous physical activities to prevent type 2 diabetes. And we have also seen from the research that the use of TOT, the training of trainers for impacting nutritional behavior among adolescents, again, based on the studies that seem to work. And if implemented, actually it will make a big difference in terms of their management of their diseases. I think that's it for today. Thank you.
Thank you very much, Prof, for being so time conscious. Ladies and gentlemen, I want to thank you for being very patient. So I think we have a panelists who are still with us. So I know there are a number of questions on the Q&A. We will not be able to answer all of them. Some of them are comments, some of them are about CPD points, and I think there's been a response that will be emailed to them. If I may just sample a few of the questions, some I've responded to. Somebody, I think this is Lynette Obiero. I don't know to whom this is directed, but Lynette is asking if it is advisable to do regular HbA1c in non-diabetic state and how often. I think this is about screening for diabetes. I'm not a diabetologist, but I think any panelist can respond to that. You see Eugene. Eugene is with us. Dr. Eugene. Dr. Katambo.
Well, good afternoon. Thanks.
Afternoon,
So screening for type 2 diabetes starts in many ways. One, you can do a fasting blood sugar. You can do a random blood sugar, but it's always advisable to have at least an HbA1c once a year, so that you can check, because sometimes you need at least 2 tests to confirm a diagnosis of diabetes. when you're doing your regular annual physical check, it's always advisable. You either do a fasting blood sugar, a random blood sugar, and if any one of those suggests that there could be hyperglycemia, whether it is glucose intolerance or it is diabetes range more than, if it's more than 5.6 for fasting, 6.8, that is pre-diabetes if it's more than that. So there are many tools we can use, HbA1c being one of them. And again, it will also depend on the available, your environment. So an HbA1c might be available here in Nairobi, but it might not be available in Turkana or the center at which you are working. But I think a basic random blood sugar can be used even to screen for diabetes.
Thank you very much, Doc. While you are at it, somebody has asked you a question, which I think is recurring, the choice of fruits in diabetes.
Well, that's a very interesting question, and I always get it. The way I answer is it highly depends, again, on what is available on the table, your belief about fruits, how you conceive fruits to be, especially culturally, as the last speaker, Prof, has just put it. What I usually do is to educate somebody about fruits. For example, I showed you a few fruits. A mango could have up to 8 to 10 teaspoons of sugar, and an orange could have up to 4 teaspoons of sugar, or a banana can have up to 6 teaspoons of sugar. Now, a good way of showing this to your patient, ask them to go and eat 2 bananas the way they do it. Check their sugars before and 2 hours after. And most of the time they tell you, oh my God, I didn't know that my sugar can shoot this much. So depending on your patient, then you can tell them you need to lower the amount of fruits that you are taking, or you take these fruits that have less sugar. And those are mainly commonly strawberries and blackberries. They tend to be a bit expensive, or you use probably an orange and make sure the quantities are really minimized. But remember, fruits and carbohydrates are what we call non-essential macronutrients. So it's not unheard of for you not to eat fruits.
Thank you very much, Dr. Katambo. Prof, someone is wondering whether we should be drinking 10 liters per day. I think this question, I get it from patients as well. How much water should we drink? Because I think somebody is wondering whether they are able to drink 10 liters per day, as you had suggested.
Right. I think what is recommended for an adult is 8 glasses and above. Less than that is not recommended, it's too little. And we have seen, like the adolescents, as I said, some of them take even less than 4 glasses in a day, which is less, and yet they need that for many functions, including the digestion, their body cells, the body liquids, Yeah, so that's what we are recommending.
Thank you very much, Prof. Dr. Muli, somebody is asking whether flossing prevents formation of plaques.
Yes, I have answered in the chat, but basically what it is, flossing removes the plaque that is already formed. You see, prevention is by choice in terms of diet, what you're eating, and how frequent you're brushing. Really, you need to brush and floss. Flossing does remove plaque in between the teeth, where it's most prone to periodontal disease and cavities. So it's important, yes. Unfortunately, when the spaces between the teeth are big, flossing becomes a little bit more ineffective. And we have other little brushes, more like what you have for test tube brushes or the brushes for the baby bottle. Little ones now, tiny ones that you can use to clean in between. And we also have tools like water flossers, which is basically a strong water jet that is able to remove the biofilm in between the teeth. So that's very important usually.
Good. Somebody is asking whether there is long-term safety profile for managing type 2 diabetes patients on low-carb keto genetic style diets. What is that, Dr. Katambo? Considering the documented health risks associated with diets high in animal protein, such as dyslipidemias, heart disease, and multiple cancers such as CA colon. I think somebody related, yes.
So a very good question, and I always get this question. And the truth of the matter is the studies that have been documented regarding keto or low carb causing all those, haven't seen any that have actually proved that such does occur. And on the contrary, actually, the studies that are like the controlled clinical trials, large observational studies, remember, diet has really become of focus in the last 10 years. And that is the time that we have now started to see a lot of clinical studies coming in. And that is actually what has disputed the fact that we knew saturated fats are bad for our health. In fact, several studies or clinical trials right now that are coming out are disputing the low-fat diet that has always been there and encouraging healthy animal fat, including eggs, and they have not been shown, actually they reduce the cardiometabolic risk factors.
Great. I think the other questions on reproductive health, Dr. Mutio Emma is saying they have run a good preconception clinic at Mama Lucy, and an anonymous attendee, I think this is Dr. Alfred Osotti, preconception counseling at lower health facilities. And I think related to that, somebody is also asking when it is safe in pregnancy to use metformin.
Okay, thank you very much, Dr. Mutie from Mama Lucy. Yes, Mama Lucy has been doing a lot of good work. We appreciate you for that. It's a very busy institution, and the obstetricians there have introduced high-risk clinic and offering preconception care. So it would be important to capture that data to see what kind of patients you get and what kind of outcomes you get from the same. It needs champions, so somebody has to be a champion and be interested in starting the clinic wherever they are, and usually the lead obstetrician should be able to do that. It can start like a high-risk clinic, and then you make preconception part of the high-risk clinic, so that would work very, very well. The other question about the lower level facilities, I think this is where policy comes into practice. So the Ministry of Health should develop mechanisms that can help even the lower level facilities to be able to offer preconception care and counseling, because if there are no obstetricians, there still are clinical officers in reproductive health, and there are still nurses interested in this kind of pregnancy that can screen them and refer them appropriately. So there should be a level-based preconception care, and that is something that can be guided by policymakers. And then for metformin, you can really start it at any time. In pregnancy, it doesn't matter. It's not teratogenic, so you can start it at any time. The only concern is for the babies that are born and for the children that are followed up, that there may be a slight increase in BMI, but these are preliminary studies. So we need more concrete data to be able to say whether metformin should be stopped. But looking at the data that we have, it's not that bad. It's just a caution that we need to have. Good. So those are the questions, I think. Yeah.
I think because of time, I think there's a question that is very interesting, and being an oncologist, we get this a lot, whether diabetes is associated with certain malignancies. Yes or no, but what we've noticed is that those who are newly diagnosed type 2 diabetes and losing weight and have abdominal symptoms should be screened for CA pancreas. I don't know what your experience is, but patients we get with CA pancreas, you find a good percentage of them were recently or within the few months to a few years diagnosed with type 2 diabetes. So I think that is the relationship that one can draw specifically with type 2 diabetes. The others, I think, because of the associated obesity and obesity being a risk factor for malignancies as well. Ladies and gentlemen, I think we have done so well. There are a number of questions which we may not be able to tackle. I think the administrators of this forum should be able to make the CPD points available to the participants, because a good number of them are asking. We have 2 minutes. Yes.
My internet has been on.
Yes, Prof.
If there's anything you want me to say, I can.
Oh, Prof, I didn't know you were around.
My internet has been very bad. If you want me to make any statement that you felt I needed to, I can.
Yes,
if there's
Prof.
none, I am obedient, compliant.
Prof, I didn't know you were in you were with us, but
now you can hear my internet is misbehaving.
Okay. Yeah, there are a number of comments. Most people are really congratulating you for the presentation. They are saying the SOP in many health facilities for this is an issue. I think somebody is asking who should be the change agents.
They've been addressed.
Yes, some of them have been addressed, and I think the issue about teamwork and collaborative approach has really been appreciated. The coordination of care, as you had, I think somebody was even suggesting that Huduma number would have been quite a strategy to, to access health records and align coordination of care.
Yeah.
Okay, fine. So I think none really pressing, Prof. You want to thank everyone for giving us their attention and attending. Our attendance was
for me.
Good.
I'm just glad that people are seeing sense that it's not the technology, it's the idea of how we use technology to coordinate.
Yes.
Thank you very much.
Thank you very much, Prof. So I think we were
Thank
very
you.
well attended.
I don't want to take anybody's extra time. I can see the numbers are good. Thank you.
Okay, fine. We had about 1,000 and I think 10 as the highest, and we still have 665 people. So thank you very much. Remember, tomorrow we have another series. You have a good evening, and thank you very much, the panelists and the presenters. You've done a very good job. I think the slides can be made available depending on the, the consent of the speakers. Thank you very much. Dr. Juka, do you want to say something?
Just to thank you, Peter, for helping us moderate the session, and thank everyone who was present up to now. We see you tomorrow.
Thank you very much. Have a good evening, everyone.
Thank you.
Thank you.